mineralocorticoids, and aldosterone. Regulation of sodium balance, water homeostasis, and blood pressure. What are mineralocorticoids? Mineralocorticoids are steroid hormones produced in the zona glomerulosa of the adrenal cortex. Their primary role is regulation of sodium, potassium, and indirectly water balance in the body. Aldosterone is the main endogenous mineralocorticoid in humans. Deoxycorticosterone has weaker activity. By controlling renal sodium reabsorption and potassium excretion, they influence extracellular fluid volume. Changes in extracellular volume translate into modifications of venous return, cardiac output, and blood pressure. Mineralocorticoid action is mediated via intracellular mineralocorticoid receptors, acting as transcription factors. Synthesis and regulation of aldosterone. Site and pathway of synthesis. Synthesized in zona glomerulosa cells of the adrenal cortex from cholesterol. Key steps involve conversion to progesterone, then deoxycorticosterone, then corticosterone, then aldosterone. Enzymes specific to zona glomerulosa, for example aldosterone synthase, allow selective aldosterone production. Synthesis is mainly regulated at the level of cholesterol side chain cleavage and aldosterone synthase activity. Main regulators. Renin-angiotensin, aldosterone system. Angiotensin II strongly stimulates aldosterone secretion. Plasma potassium. Hyperkalemia stimulates, hypokalemia suppresses aldosterone release. ACTH acutely stimulates but has modest chronic influence on aldosterone production. Plasma sodium and blood volume indirectly modulate aldosterone via renin release from the kidney. Mineralocorticoid receptor and mechanism. Mineralocorticoid receptor, MR. MR is an intracellular cytosolic, nuclear receptor expressed in kidney, colon, sweat and salivary glands, and heart. Both aldosterone and cortisol bind MR with high affinity. Tissue specificity is ensured by local metabolism of cortisol. In aldosterone target cells, 11-beta-hydroxysteroid dehydrogenase type 2 converts cortisol to inactive cortisone. MR activation leads to changes in gene transcription controlling ion channels and transporters. Cellular mechanism of action. Aldosterone diffuses through the cell membrane and binds MR in the cytoplasm. The hormone receptor complex translocates to the nucleus and binds specific DNA response elements. Transcription of genes such as epithelial sodium channel, ENA-C, subunits, and sodium-potassium ATPase is upregulated. Resulting protein changes increase sodium reabsorption and potassium and proton secretion across epithelia. Renal actions of aldosterone. Key transport effects along the nephron. Distal nephron and collecting duct. Principal target segment for aldosterone action in the kidney. Increases expression and activity of ENA-C in principal cells. Stimulates basolateral sodium-potassium ATPase, enhancing sodium reabsorption and potassium uptake into cells. Effects on electrolytes. Promotes sodium reabsorption from tubular lumen into blood. Enhances potassium secretion into tubular lumen leading to kaliuresis. In intercalated cells, increases proton secretion, influencing acid-base balance. Consequences for fluid balance. Retained sodium increases extracellular osmolality, drawing water and expanding volume. Expansion of extracellular and plasma volume raises venous return and cardiac output. Sustained activation contributes to long-term control of arterial blood pressure. Blood pressure regulation by aldosterone. Hemodynamic impact. Increased sodium and water retention expand intravascular volume. Higher plasma volume raises preload, stroke volume, and cardiac output. Long-term, this supports maintenance of arterial pressure when volume is threatened. Excess aldosterone may lead to persistent hypertension and vascular remodeling. Interaction with other systems. Integral part of the renin-angiotensin aldosterone system coordinating volume and pressure control. Works with sympathetic nervous system, vasopressin, and natriuretic peptides to fine-tune blood pressure. Natriuretic peptides inhibit aldosterone secretion, promoting sodium loss and pressure reduction. Local cardiac and vascular MR activation may contribute to fibrosis and target organ damage. Clinical syndromes of aldosterone excess. Primary and secondary hyperaldosteronism. Primary hyperaldosteronism. Autonomous aldosterone overproduction by adrenal cortex, for example adenoma, bilateral hyperplasia, leads to sodium retention, hypertension, and suppressed plasma renin activity, often associated with hypokalemia and metabolic alkalosis. Secondary hyperaldosteronism. Aldosterone elevation driven by increased renin and angiotensin II, seen in conditions with decreased effective arterial blood volume, such as heart failure or cirrhosis. Kidney perceives underperfusion, activating RAS despite systemic volume overload. Clinical significance. Contributes to resistant hypertension and cardiovascular complications. Recognition allows targeted therapy with mineralocorticoid receptor antagonists or surgery. Early diagnosis improves blood pressure control and reduces organ damage. Aldosterone deficiency and resistance. Hypoaldosteronism is often a hidden condition because it lacks distinctive external physical features like the skin darkening seen in Addison's disease. Instead, it is characterized by internal electrolyte imbalances, specifically high potassium, hyperkalemia, and low sodium, which are typically visualized through clinical charts and diagnostic data. Hypoaldosteronism may result from primary adrenal insufficiency or isolated aldosterone synthesis defects. Leads to sodium loss, hyponatremia, hyperkalemia, and low blood pressure. Volume depletion can cause dizziness, orthostatic hypotension, and fatigue. Treatment focuses on hormone replacement and correction of electrolyte disturbances. Pseudohypoaldosteronism. Tissue resistance to aldosterone despite normal or elevated hormone levels. Mutations in MR or ENAC lead to impaired sodium reabsorption in the distal nephron. Clinical picture mimics hypoaldosteronism with salt wasting and hyperkalemia. Management includes high salt intake and sometimes additional pharmacologic measures. Mineralocorticoid pharmacology. Agonists and antagonists. Agonists and clinical use. Fludrocortisone is a synthetic mineralocorticoid with strong sodium-retaining effect. Used in primary adrenal insufficiency and some forms of hypoaldosteronism. Dose is titrated to normalize blood pressure and electrolytes without causing edema. Monitoring includes body weight, blood pressure, and serum sodium and potassium. Receptor antagonists. Spironolactone and eplerenone block mineralocorticoid receptors competitively. Indicated in primary hyperaldosteronism, heart failure with reduced ejection fraction, and resistant hypertension. Reduce sodium retention, lower blood pressure, and limit cardiac remodeling. Adverse effects include hyperkalemia. Spironolactone may cause endocrine side effects.